Thank you, David, for that introduction. So I'm going to expand on what David said about the dearth in treatment strategies in terms of providers who know how to treat obesity, but also other barriers and disparities. So this is, I just did this as a schematic of the obesity treatments, and I categorized them in terms of benefit on the left and risk on the right in terms of complications. So first of all, we've had an explosion in both treatments and providers who can treat obesity since really the early 2000s. In 2013, the AMA designated obesity to be a disease. And at around the same time, 4 new medical drug treatments for obesity came out, approved by the FDA. And those treatments are in the gray, the amount of weight loss you can get with those treatments, about 5%, at best maybe 10%. So we're talking about, in the case of a patient whose BMI is over 30, or weighs 200 to 220 to 250 pounds, let's say, we're talking about 25 pounds of weight loss, just to put this in context. But we have this rapidly evolving field of obesity medicine, and you saw from David's slide showing the number of diplomats per year. In 2011, we started the certification for obesity medicine, so that increase has been astronomical. Even though we still don't have enough specialists to treat all the millions of patients suffering from this disease, it's still a dramatic increase from where we used to be. So we do have treatments. We also have changes in surgical approaches to obesity for those patients with extreme obesity, and those changes have made it a much safer procedure over the past 20 years. And you see the results of the Roux-en-Y gastric bypass and the sleeve gastrectomy in red. You can get 30% weight loss with those procedures. That means about 100 to 150 pounds kept off indefinitely. The medications work as long as the medication is taken on a daily basis for the most part, and the medications are appetite suppressants. In the middle there, between obesity prescriptions and surgery, are a myriad of novel therapies that have just literally come out and are not covered by insurance, neither are drugs, we'll talk about that. And those are devices that are either surgically or endoscopically placed that try to simulate the effects of gastric bypass surgery and the sleeve gastrectomy, but as you can see from the weight loss, don't quite make it. So that is what we have on the left for treatment of obesity. And the side effects, basically you can see on the right that the more efficacious the treatment, the higher the complication rate. So that's the catch-22, let's say, about the benefits and risks of obesity treatments. On top of all of this, there are, for all of the patients in this country, and there are millions who are eligible for a surgical treatment for their obesity with BMI over 40, which is extreme obesity, only 1% get the procedure. And that's about 200,000 procedures per year in this country. You may ask why. The why is because of barriers that include patients not accepting the idea of a surgical intervention for their weight problem, and doctors also not accepting the risk of surgery for their patients. Because for the most part, bariatric surgery is a covered benefit under most insurance plans with the right BMI. In terms of drugs, only 2% of the population in the United States eligible for a drug treatment get it, and that is mainly because of lack of insurance coverage for drugs. You may ask why, and that's a very good question, but also because of other barriers such as the dearth of doctors who can treat obesity and understand how to use the medications, as well as patients' unwillingness to undergo a drug treatment. Dr. Murthy this morning said that people would rather take a drug than take a walk, but not if the drug costs $200 a month, and they believe that their weight issue is under their control. This slide reminds me to talk to you about the gaps between the guidelines that I helped write. I was one of the expert panelists that got together to write the 2013 obesity treatment guidelines that were published in Circulation and also in the Obesity Journal. And these were guidelines based on current evidence about how to treat obesity and how to identify and assess obesity for primary care providers. And on the left are the guidelines. They're very simple. Use the BMI to identify risk and advise patients of this risk. Use the waist circumference to identify risk. It just involves taking a tape measure and measuring the waist circumference. If your waist is greater than 35 inches and you're female, that's too much body fat in your visceral area. If your waist circumference is already over 40 inches and you're male, you have an increased risk. We showed evidence, we found evidence in the literature to suggest that as little as 3% weight loss will reduce the risk of developing diabetes due to obesity. So as little as 3%. We advise doctors to prescribe a set number of calories per day and that there is no ideal diet. It's all about calorie intake. And the strongest recommendation was to advise adults with obesity who met criteria that surgery may be an option for them. There are gaps in implementation of these guidelines. Clinicians, first of all, often fail to diagnose overweight and obesity or even discuss weight management with their patients. You may ask why. When you have 10 to 15 minutes per patient in a very busy PCP practice, it's very difficult to approach the issue because it's such an emotionally charged issue with most people, even for the doctor. And then again, as we saw with David's slide showing the number of clinicians who are specialized in obesity medicine, we have doctors who have not been trained to treat obesity with behavior change. And by the way, all of the treatments I showed in the first slide are meant to be adjuncts to behavior change and not to be used alone because they don't work. Not even bariatric surgery works alone without diet and exercise. And then the biggest gap for the reason why surgery is not often even addressed with patients who are eligible is that there is lack of training, the provider attitudes are at play. Sometimes it's a lack of reimbursement, but Medicare, Medicaid does cover obesity surgery for those who are eligible. But the fear of complications, especially on the patient's part, I see that every day in my practice, and then lack of time to counsel patients, because not only should you be counseling patients before surgery, but certainly after surgery as well. There are disparities. The treatment of patients with obesity is complicated by a range of socioeconomic, geographic, cultural, biological, and environmental inputs. And the treatment of obesity is dependent on those inputs as well, so that the underlying causes of the disparities have clinical implications for treatment. There's a differential response to obesity treatment across certainly racial groups. And I have just a few examples of that. So the evidence, certainly looking at gastric bypass surgery and sleeve gastrectomy, as well as medications, show that African Americans tend to lose less weight in clinical trials for these treatments as compared to non-Hispanic whites. And that is probably a complicated interplay of physiologic drivers of energy imbalance and access to care, as well as treatment responses. For Roux-en-Y gastric bypass surgery, as you know, it also cures type 2 diabetes, not just it doesn't cure obesity, but it can cure type 2 diabetes. But while it keeps hemoglobin A1C levels at bay in Caucasian patients, unfortunately, we have found that in African Americans, those blood glucose levels rise after two years after bariatric surgery. So we have a huge disparity in how gastric bypass surgery works or doesn't work in African Americans as compared to Caucasians. We're also seeing some differences in the Hispanic population, but again, this data is just coming in now. Now, our work has shown that beyond the cultural, the access to care, the geographic, and the socioeconomic, there may be an inherent physiologic difference in how different racial groups develop the comorbidities. For example, we have found that African Americans are much more insulin resistant than Caucasians with similar BMIs. So there might be something genetic or physiologic between racial groups such that obesity in one group based on BMI is very, very different than obesity in another group. And this complicated interplay between socioeconomic, educational, geographic, access to care, and the physiologic makes it very, very difficult to treat obesity under these conditions. So how are we going to address this? We have to, what we have to do future-wise is study different racial, ethnic groups and minority groups when we're doing studies on new treatments. And this means going back and looking at different medications and the devices as well as bariatric surgery. And we're not just talking about racial groups, even though I gave you those examples, but there are other socially distinct groups, such as rural versus urban, those with mental illness. Because of their mental illness, they're more at risk for obesity, but also because of the medications that are typically prescribed for those patients as well, and those with alternative lifestyles. And we also need standards for culturally appropriate and tailored care. There's lots of evidence in the literature that using culturally appropriate treatment may work, but we have no idea, there's no standard for what's culturally appropriate for certain racial ethnic groups. And we also need to explore social and physiologic factors related to treatment outcomes for non-behavioral therapies such as medication and bariatric surgery. This is certainly a big gap in treatment as well. So the challenge is, how are we going to deal with barriers to effective treatment? We need more training for clinicians. We need to somehow get more time for clinicians who decide to become obesity medicine specialists to actually effectively treat. We have to deal with lack of patient motivation to lose weight because of frequent failures, lack of reimbursement. How can we improve the clinical treatment of obesity, including the BMI as a fifth vital sign, adding BMI to the patient charts? Believe it or not, this still is not happening. We need scales that report BMI and can actually go as high as 600, 700 pounds, because typically scales in doctors' offices only go to 350. We need medical equipment in the office that can accommodate larger size patients. How do we improve capacity for treatment? We need to increase training. We need accessibility to those with lower SES status to obtain medication and devices and even surgery, because right now, for the most part, except if you are 100 pounds overweight, these treatments are not covered by third-party payers. So thank you. I'm going to leave it at that. We can talk about the rest during the panel.